Broadcasting Network TV, aka LCBN TV, is committed to bringing the transformation message of Jesus Christ into homes across the world, providing hope in the most desperate situations. We are passionate about souls, reaching the lost, the hurt, and the lonely, and by a click of a button, God can change a person's life forever. Watch LCBN TV channel 24/7 on UK Freeview channel 271, Roku TV, Amazon Fire TV, Android TV, Apple TV, See Love World, Google TV, LCBNTV.com, LifeComTV.com. Download LCBN TV app from Google Play and App Store. LCBN TV, just in time.
Hello, good evening, viewers, and welcome to Health Matters with Dr. Olani Ajay. It's a pleasure to have you with us on this platform tonight. And once again, we're looking forward to an interesting time. And I've got with me again tonight to do justice to the topic of today, which is sleep disorders in young children in the pediatric age group. I've got Dr. Akiyemi Ajay, who is the current chair of the Department of Pediatrics, Advent Health for Children. He's a renowned pediatric pulmonologist in the Florida area, and he's the president and medical director of the Children's Lung Asthma and Sleep Specialist Winton Park in Florida, USA. Dr. Ajay, you're welcome to the program, and thank you for obliging us all the time.
Thank you very much for having me on.
Yeah. It's an interesting topic we have today because I know as a young man from an African parent, there is a lot of things that happen when we're younger that people think it's abnormal, and without realizing that it could be linked to a medical disorder, really. Things like bedwetting, screaming at night, going to the fridge where you're not supposed to, and thinking you're just stealing ice cream without realizing all sorts of other things. And I'm hoping that you'll be able to do justice to that for us tonight. So when we talk about sleep disorders in pediatrics, in young children, what are we actually referring to? Because I know all of us sleep and all that. What are we actually referring to?
So, the sleep disorders in children is surprisingly quite similar to sleep disorders in adults. And by that, I mean, the easiest way to look at sleep disorders is to break it into about 5 different things. You have disorders that are associated with insufficient sleep. So that would be generally what you would describe as your insomnia patients, which means people who have difficulty going to sleep. But then when you break that down, depending on the age, you can have what we call behavioral insomnia of childhood. There is a limit setting type, which is where you have a child who keeps on trying to find excuses to come out of the bedroom. Every time you tell them, go back to bed, oh God, they come back 30 minutes later, I have to urinate, I'm thirsty, I need a drink. And that's a limit setting disorder. And that is typically associated with a parent not setting firm limits at that stage in development. And then you can also have what we call a sleep onset type, which is where you have children who have to have a specific condition present in order for them to sleep. So in essence, you have the child who will only fall asleep if the mother is in the bedroom with him. If the mother is not there, he will not fall asleep. If anybody else is there, he will not fall asleep. But if his mother lies beside him, within a second, he will fall asleep. But it doesn't actually have to be a parent. It could be an object. The child who cannot fall asleep unless a specific teddy bear is in a specific angle or a specific blanket is in a specific place. So they develop what you call a sleep onset association, where without that object or situation being present, they simply cannot sleep. And those are what we call the behavioral insomnias of childhood. And then you can have chronic insomnia of childhood, which is where you just have that person who is always, for some reason or the other, had difficulty sleeping. Some of them will have insomnia related to a medical condition like autism and the rest. And right there, we've only just started, and that's just insomnia. Then if you said, okay, let's shift away from the insomnias, what else is there in children? Well, then you're looking at disorders of excessive sleepiness. Which is the exact opposite of insomnia. And now you're dealing with children who have conditions such as narcolepsy. And I know when everyone thinks about narcolepsy, you think about it as an adult disorder. However, the fact of the matter is virtually 100% of people with primary narcolepsy will develop their narcolepsy symptoms before the age of 20. In fact, most will develop their initial symptoms somewhere between 9 and 12 years of age, when they begin to develop excessive sleepiness. So one of the things I tell parents, for example, is if you have a teenager who needs to nap every day and will pick a nap over going out to socialize with his mates, you have to consider that there's a problem there, because that is an unusual pattern to see in a teenager. Naps in most children are absent once you're over 5 years of age, and they shouldn't need a nap until you're much later in life. So if you have someone who's consistently needing a nap, that's an issue. If you have someone who's fallen asleep in class, that's an issue. Whether it's an issue of a disorder of excessive sleepiness or something affecting the quality of their sleep, which we would then unpack. But basically, disorders of excessive sleepiness do exist in children. Then if we move away from the disorder of excessive sleepiness, and there are other forms of it as well, then you look at movement disorders in sleep. So then you have movement disorders in sleep, and now we're talking about things like periodic limb movement in sleep and restless leg syndrome and myoclonic jerks, where people are literally twitching or tweaking or kicking or moving in their sleep. And I'm sure there's several people who will tell you that they simply cannot sleep with their kid because he will kick them out of bed or kick them off the bed, and they wake up with bruises. But it isn't just the fact that they're kicking you out of bed, but all of that kicking and movement is also disrupting their own sleep. Absolutely. So you have a child who wakes up in the morning and appears tired or non-restored from their sleep, and you're wondering, well, why is this child so tired if he just had a full night of sleep? So we deal with that. Then you have a fourth group of, when we break it up, which is your disorders of arousal. And this is where we have what we call our parasomnias. That's where you have your night terrors, your confusional arousals, and sleepwalking. And these are all things that typically happen out of deep sleep, where, in the case of a sleepwalker, for example, this child gets up, walks about, actually carries out activities that would seemingly appear to only be things that someone who is awake can do. So they might actually walk up to the fridge, open the fridge, take out food. They might actually make themselves a sandwich, eat it, and go right back to bed. But what normally tells the difference between someone who's awake and them is that they normally make a mess. It's highly unlikely that they'll make the sandwich and then put the jam and the butter back in the fridge, or that they will tie up the bread bag and leave it in a nice corner. They won't do that. They'll drop everything everywhere and leave crumbs all over the place. And they'll have no recollection of the events in the morning. And that's what we refer to as sleepwalking episodes. They can be dramatic. People can walk out of the house, walk down the street. I've had people walk across a field into a barn, and then the parents found them in there. But it could be anything like that. You can have night terrors where someone just wakes up screaming in the middle of the night. They're screaming, they're yelling, you're talking, they're talking, and then it suddenly occurs to you that they're not actually talking to you. You're talking to them, but they're not actually responding appropriately to you. So you can have those. And those are what we call the non-REM parasomnias. And then you have things like bedwetting, which is typically put in that group as well, which is actually normal in most people up to about the age of 9. And so you can have what we call primary or secondary enuresis. It's always commoner in boys than girls in general, and girls tend to potty train in general much faster than boys, both in the daytime as well as at night. And then you have nightmares, which is a disorder that comes right out of REM sleep. You can have nightmares, and you can have what we call REM behavioral disorder, where people actually act out their dreams. And that can actually be problematic if you have someone, especially a young or middle-aged adult, who is acting out their dreams frequently. That can be a sign, a marker to the later development of a condition such as Parkinson's disease. So it's actually something that sounds cute to say they're acting out their dreams, but it could actually lead to bad things down the line, and people need to be aware of that. And then the final way we group sleep disorders today is to then look at what we call sleep disordered breathing, which has everything to do with snoring, to what we call sleep apnea, which is when people actually stop breathing in their sleep, and everything that's in between, and how that affects both the quality and the quantity of sleep that you have throughout the night.
Thank you so much. Wow, that is a lot of information. And I'm hoping you'll be able to break a few of those things down for us tonight. You did mention something. You talked about adequate sleep. And I would really like to ask you about that. But before we do that, I don't want our audience to be confused when you talk about teenagers and things like that. What is the pediatric age group?
So, it's kind of a funny thing. Growing up in Nigeria, we would consider everyone who's less than 21 to still be a kid. In America, they consider 18 would be considered the high point of being a kid. After 18, you're considered an adult. Everything I talk about, once you're above the age of 16, the parameters that I will talk about for anyone above 16 typically holds true for most people till about the age of 50, when sleep characteristics change. So it will still be relevant even for a teenager or a young adult.
I see. Thank you so much. So what would you regard as normal or sufficient sleep?
So if we're talking about normal sleep, for example, and we'll break it down into different ages. So let's start from the beginning. So for a newborn through about 3 months of age, the expectation is that they're going to sleep between 14 to 17 hours in a 24-hour period. So it's not one solid block of sleep. It's actually called an ultradian pattern. So they have they sleep, they wake, they eat, they poop, they sleep, they wake, they eat, they poop, and they just keep going around that cycle. So you expect them to have multiple naps inside that. Between 4 to 6 months of age, that's going to come down. And now you're expecting them to have between 13 to 16 hours of sleep in a 24-hour period, of which there will be about 2 to 3 naps built in there. But the nighttime sleep will begin to become very consolidated. By 6 months of age, most children have a consolidated nighttime sleep where they do not need to wake up to take a bottle or something they can literally sleep through. Between 6 months and 2 years of age, we're looking at between 12 to 14 hours of sleep in a 24-hour period. So in there is still an expectation that they will have about 2 naps in there. Between 3 to 4 years of age, now we're looking at between 11 to 13 hours of sleep. We still expect them to have 1 nap. So the nighttime sleep will ideally be between 10 to 11 and a half hours, and then they'll have about an hour to an hour and a half of a nap through that. By the time most children are between 4 and 6 years of age, they're down to about 10 to 12 hours. After the age of 5, most children will stop napping. And so we expect that they will be napping till about 5, no later than 6. By the time a child is 6, they should really be done developmentally with requiring a nap during the daytime. For your 7 to 11-year-olds, they need between 9 to 11 hours. Wherever possible, I always ask parents to try and err to the higher side. So if I'm saying 9 to 11, try and get them as much as 11 if you can, but they should be fine with 9. For your 12 to 15-year-olds, they still need between 8 to 10 hours of sleep. Your 16-year-olds and above typically need about 7 to 9 hours. And then for most adults, typically can function very well with as little as 6.5 hours of sleep. Ideally, I advise adults try not to get more than 8 hours of sleep, because beyond that, the sleep can actually become detrimental to you in terms of your health in general. So 6 to 8 hours of sleep for adults. And for your teenagers and young adults, we would say between 7 to 9 hours. Anyone above the age of 5 should not be napping in that group until later adulthood. If you've got someone who is napping or needs a nap consistently, there's either something wrong with they either have a disorder of excessive sleepiness, or there's something wrong with the quality of their sleep, assuming they are getting the amount of sleep they're supposed to be getting.
Thank you so much. So really, sometimes we shouldn't think about excessive sleep as laziness.
Exactly.
It might be something else.
In fact, it's funny that you mentioned that, so I really should harp in on this. In virtually every late onset, in virtually every late diagnosis of narcolepsy I've made, every single one of those kids has mentioned in bitterness how they got tired of being told they were lazy, unmotivated. It's just the things that they have been told. By the time we get them, a lot of those kids are very bitter. In fact, one of the shames of narcolepsy is the average time from the first presentation of symptoms to diagnosing a person with narcolepsy is typically between 12 to 15 years, which is tough to go through your entire formative teenage years sleepy with everyone thinking
you're just lazy.
You're lazy.
That is, and that could actually lead to all the psychological problems, lack of confidence, loss of self-esteem, and other issues that might actually follow them into their young adulthood.
Well, think about it this way. Narcoleptics, 25% of narcoleptics have depression as a secondary condition. 35% of them have general anxiety disorder. Yeah. They have a significantly higher suicide rate than the general community. And in schools, they have a 50% failure rate. I tell people all the time, if you have a child in your classroom that seems bright when you engage them, that you can't define what the learning disorder is, but they're not doing well. Or if you have a child who's been held back a school grade and they just look tired, you have to strongly consider the fact that that child may have narcolepsy, because it doesn't matter how bright a child is. If they're sleeping through your classes, they simply can't learn. It doesn't mean they're stupid. They just can't learn, especially when they're younger.
Yeah. Thank you. And I'm sure parents who are listening to this will pick one or two things out of tonight's program. And please, just to let us know that we can ask that questions directly on YouTube or on Facebook, live questions, and with Dr. Ajayi will be very, very happy to help us deal with. My next question to you, Dr. Ajayi, is this: are there cultural-based differences in sleep patterns and in definition of sleep problems?
There definitely are, because, depending on where you are in the world, one culturally and socioeconomically, for example, our expectations about sleep are very different. If you lived in a one-bedroom house with 6 siblings, you all slept in the same room. And so defining things such as sleep onset association may have been very difficult to define, because the child always had another sibling or parent or someone in the bedroom with them. And so they didn't have that. Same thing if you had to share your space with a lot of people, they were probably a bit more stern with you when it came to things like limit setting disorders. So we clamped down on those things very quickly. Snoring, for example, a lot of people will look at a lot of people are very surprised when I mention that snoring is an issue, for example, because they have grown up in a house where the father snores, the child is an identical, just tiny copy of his father. It's like a little clone of his dad, and he snores exactly the same way his father does. And so the typical assumption is,
it's normal.
Snoring, but you should hear his father snore. He just snores like his father. And then you'll have to explain to them that, well, it's not, it's abnormal. It's abnormal in his father. You might not realize it, but and it's a big problem. For example, back home in Nigeria, a lot of people snore like crazy, and people have conditions like sleep apnea. I mean, Kitney, we grew up back home. Remember one of the funny things they used to say was, they'll say that the person died in his sleep, and they'll say, oh yeah, somebody choked him in his sleep. I'm like, dude, you weren't choked. It was your own tonsils or your own throat that simply closed on you. And they will tell you that, look, if they call your name 3 times in your sleep, they'll say, oh, we heard him cry out in his sleep. And I'm like, oh my gosh, this is sleep apnea. So, yes, culturally, lack of understanding of why some things happen leads to us failing to diagnose certain conditions that may exist. I'll give you one simple one. I've actually had a patient who came to see me from Nigeria with twins, and one of their issues was these kids would wake up in the middle of the night and literally could not move. So they had what we call sleep paralysis, which is a classic feature of narcolepsy. Well, the assumption that they had, of course, was that there was a spirit holding these kids down in the bed. And so when I told their mom that, no, this is just sleep paralysis, because these kids had everything. They had the hypnagogic hallucinations, they had the cataplexy, they had the excessive daytime sleepiness. They were classic narcolepsy patients. And I told them, there is no spirit doing any of this. This is just narcolepsy. And that's part of the problem we have, is the knowledge base affects what we assume culturally is a normal or abnormal sleep pattern. But truthfully speaking, I think a lot of the cultural expectations we have to do sometimes with our socioeconomic status, or our lack of an understanding of the basis of which sleep exists.
And in some way, it also depends on a lot of other discussions that goes around in certain communities, and the way people view things, just like you said about the spiritual aspect of things and all sort of things like that. And it's interesting that the person who actually suffers is the child.
Yes, sadly.
And that is painful to watch sometimes when you see a child going through all this and it seems that nobody understands.
In fact, it's funny. One of the things I tell people all the time, that sleep disorders in children are an orphan disorder. And I call it an orphan disorder because most children sleep alone. At least in America, it might be different back home, but in America, most children, or a lot of children, sleep alone in their own bedroom on the other side of the house from where their parents sleep. So virtually every sleep disorder they have has no witness. No one sleeps with them, so you can't tell if they're snoring. You can't tell if they're sleepwalking, having parasomnias or night terrors, because you're not there with them. You know, if they don't come out of the room, you don't even know they have nightmares. And so for a lot of children, their sleep disorders only become a recognized problem when it begins to affect their parents' sleep. So because the kid is screaming, running through the house, or they're afraid he's going to walk out of the house and now they can't sleep, or he's going to school and he's coming back with bad grades and now nobody can sleep because of the stress and all of that. So until a child's sleep disorder begins to affect somebody else in the household, it's never really considered or taken seriously.
Wow. And that's a serious issue, isn't it? And actually, what I was gonna say about you did mention something that's quite important, and I'm hoping that you'll be able to talk to us about sleep hygiene. You said about setting boundaries and things like that. Yes. At the early stage, to give a child a pattern and kind of a regular routine is important. I'm sure we'll be able to touch that towards the end when we talk about things that are important that we can do without going to technical or medical, or all the little things that we can put in place.
Correct.
So we've talked a little bit about the signs and symptoms of sleep disorder in children. But are there things, you've quite covered a few bits, but are there things that are telltale signs that if people see, they should be actually saying, no, I need to go speak to my primary care physician or to my GP or to a medical colleague or friend or anybody that can help me? What are those telltale signs that you can say to our audience tonight that they should look out for?
Cool. So I'm going to divide them into two things. The telltale signs while a person is asleep, and the telltale signs when that child is awake. So if we look at telltale signs while someone's asleep, signs that something's not right. Number one, snoring. Snoring is not normal in children. It doesn't mean that it is a medical problem if you snore, but snoring is actually never normal in children. So that's the first sign that something isn't right. Two, restless sleep. That restlessness of sleep. Kicking or moving in sleep is not normal in children. They should not be a windmill or helicopter in bed. And the sheets shouldn't be all over the place. That is a sign that their sleep is not normal. Three, the child sleepwalking, confusion or arousal, so waking up screaming, crying, disrupted in sleep, those are not normal. If you're seeing those in sleep, those are actually not normal. Those are probably the three classic things I would say while a person is asleep are not normal. Now, if we say, what about when a person's awake? Well, it should not take a child more than 30 minutes to fall asleep. So if it's taking a child more than 30 minutes from when you say go to bed to when they're able to fall asleep, that is not normal. That is prolonged sleep latency. Something's unhealthy or wrong with their sleep. So basically, difficulty falling asleep is abnormal. Waking up in the morning after adequate sleep, which we've defined by the amount of time we talked about earlier, but waking up in the morning after adequate sleep and still feeling tired or not rested is not normal. That is a sign of insufficient. That's a sign of a sleep disorder as well. Waking up multiple times during the night is not normal. Now, it is true that we rouse from sleep frequently. In fact, we rouse from sleep normally anywhere from 12 to 15 times an hour. However, these arousals are typically between 3 to 8 seconds, and we go right back to sleep. We're not even aware that we woke up. But if you're having true awakenings where you're waking up aware of your environment and all, you should not be having more than a few of those a night. If you're having multiple ones, that is abnormal. So that would be considered very abnormal as well. And then finally, and probably most importantly, that I tell parents all the time, anytime you have a child with difficulty focusing, concentrating, learning, those are all potentially signs of poor sleep. It doesn't mean you cannot have a neurobehavioral disorder such as attention deficit disorder or attention deficit hyperactivity disorder. You may still have those problems or those true diagnoses. However, in any child who's being given those diagnoses, in my estimation, should have a complete sleep evaluation. It doesn't have to be a sleep study, but a complete sleep history should be taken from that child. And if there is a sleep disorder, it should be managed because it will make the management of all those other issues easier.
Thank you so much. And I'm sure some of the people that are on some of our audiences tonight who are lecturers or teachers or who manage young people in schools and in places where they learn will take some cues from what we have been saying tonight. We've talked a little bit about the different type of sleep disorder in children. Well, you did mention something that I found quite interesting, that if somebody sleepwalks and then wakes up and lives everywhere untidy, what of if he's generally an untidy person?
Well, then he's gonna be a hurricane.
All right, thank you. So when we talk about the different types of sleep disorder in children, I know that we didn't have enough time to kind of cover up the most. Which ones would you say are quite common that our audiences will particularly really want to know about tonight, that we can kind of zoom in on a little bit in the time that we have tonight?
So that's tough, especially for me because I see everything all the time.
I know.
I would say, I think we've sort of touched on sleep disordered breathing because that's a big one. If you think about it just from a population perspective, 10% of children snore and between 2 to 4% of children have sleep apnea. So we're talking 4 in every 100 kids. So obviously that's a big one. But with sleep apnea, quite frankly, the easy way to look at it is if you have a child that snores, you should talk to your primary care physician about it. If you have a child that snores and you have also witnessed them stop breathing in their sleep, then you definitely want to talk to your primary physician about it. The one concern I always tell parents is the fact that you haven't seen your child stop breathing in their sleep doesn't mean that they're not doing it. They might be doing it while you're asleep, or it may be so subtle that you're not noticing it. And it's different. The parameters are different for adults and children. So while we say adults can stop breathing for 10 seconds, when we look at children, we look at cycles of breathing. So it could be 2 cycles of breathing. So for a 3-year-old, that might be as short as 4 seconds. Now, how many parents can actually tell if their child stops breathing for 4 seconds? So those are important things to note. They're more common it's more of an issue if you've got someone who's got big tonsils or adenoids. A person with allergies might struggle more with it. A person with asthma will have significantly worse sleep apnea, and sleep apnea will also make their asthma worse. So those have to be looked at and treated. And then obviously, if you have a child who was a preterm delivery, for example, they are 5 times more likely If they were an extreme preemie, they're 5 times more likely to have sleep apnea. And for a population that have things like sickle cell disease, they are 6 times more likely to have sleep apnea. So important to know. And if you have a child, for example, who has Down syndrome, well, virtually a third of children with Down syndrome will have sleep apnea by the age of 3, and about 70% of them will have it by the age of 18. So we screen our Down syndrome patients very quickly for sleep disorder breathing. It's really important in that group to screen them, because one of the things we know is associated with persistently prolonged low oxygenation is its impact on executive functioning and IQ. And if you have Down syndrome, you simply cannot afford to give up any more IQ points because you're having sleep apnea and low oxygen saturation. So they need to be screened and looked at very quickly and very early. In the case of our sickle cell kids, we cannot afford to have them have low oxygen levels, because that increases the likelihood that they will have crisis, which is another big issue for them. So, I mean, I think that kind of should summarize somewhat the importance, I hope, for our parents out there to at least understand that snoring and sleep apnea needs to be taken very seriously. And finally, on the neurocognitive side of it, sleep apnea is associated with a decrease in executive functioning and learning, as well as focusing and attention. So if you have a kid who snores and is doing poorly in school, go and get the snoring evaluated. That could be an issue. So I would cover that as sleep disorder breathing.
Yeah, thank you so much, Dr. Ajay. So when we talk about all this, because you've mentioned a few things that for me actually is a little bit concerning if you have a child that has an untreated or undiagnosed sleep disorder. So you've mentioned a few of this, but if we can just kind of zoom in on those things for our audiences to be able to pick up on, what are those things that the long-term impact or short-term impact of undiagnosed sleep disorder?
Yeah. So let's start, for example, with, we'll talk about one of them. Let's look at something like narcolepsy, right? So like I said, most narcoleptics develop symptoms somewhere between 9 to 11 years of age. The first symptom that they develop is daytime sleepiness. There also seems to, narcolepsy, especially when it develops in girls, for example, one of the classic things about them is they're never disruptive in class, but they become disengaged. So they're more distracted, and they're incapable of focusing as well. The boys tend to always be more disruptive in general, but with our narcoleptic boys, they're actually not that much more disruptive. They're just really poorly focusing, and then they withdraw into a shell. They have a lot of, the biggest concern I always have with a young narcoleptic is the neurobehavioral and neurocognitive development. The number of children who will fail or go into a situation where they have failing school grades is alarming. In fact, one of the things I tell the pediatricians in my local area here is that anytime you have a child below the age of 15 who has been held back a school grade, please do some form of sleep evaluation. I don't care what learning disorder you think they have, because there's nothing more tragic than knowing that all we had to do was help a child stay awake and we missed it. I mean, that to me is simply unforgivable if the answer was simply to help a child stay awake. Now, imagine the frustration for a lot of these children. They're struggling to stay awake in class. They're struggling to focus. They withdraw they don't want to go and hang out with friends at the end of the day because they're tired and sleepy. So they become more isolated in general. They develop affective disorders. So depression becomes a big issue. You know, and you can tell when you see them. They're typically sad. They typically look like they have no drive. They're more anxious. They don't want to be around people. One of the saddest things I see with a narcoleptic, for example, one that has cataplexy, is their unwillingness to laugh, because they understand that laughing will trigger their cataplexy. and they'll have that sudden loss of muscle tone or weakness in either their arms or legs. You don't have to collapse to the ground and not be able to move. It could be as simple as just blurring in vision in one eye, because it can affect any skeletal muscle, or the kid that just drops every plate he holds, or his knees wobble. I mean, I've seen it all, but people don't understand what it means to not want to take a good laugh. That is really, really a sad thing to actually watch. But we see that. We see that a lot. All the other neuropsychiatric diagnoses are more common in them. Depression's a big one. I remember seeing a twin girl. When I first met her, she was about 15. And when I diagnosed her with narcolepsy off just a history and physical the first time I saw her, it was really a history. I've never seen a human being so happy to get a lifelong diagnosis, but she was so happy. All she kept on saying to me was, I knew it. I know I'm not stupid. I know I'm not lazy. I know I could do this. I've always told people there was something wrong. I knew it. And she was just so happy because finally
she found
someone had nailed it, that it wasn't her. She wasn't an undriven, lazy child. And that hit me so hard, because you never realize how much of an impact these things are having on people's lives. We're lucky. We wake up in the morning, we get up and we go, and our lives work, but we have no idea what these people are going through. And then I remember another father. He had a 9-year-old boy, and when I told him his son had narcolepsy, the father, he stopped for a second, then he said to me, he has a medical diagnosis. And I said, yes. And he said to me, so you mean I have punished him? I have deprived him of toys. I have taken things away from him. And you were telling me this whole time it was a medical problem? And I said, yes. And his next question to me was, why did his pediatrician not tell me this for years? That this has been going on for years. Why didn't anyone tell me this? And by now, this kid had been held back a school grade. So, and you and I both know, Nee, growing up, what it means to be held back a school grade and how that affects you psychologically. Even with little kids around you, to be that kid that's been held back in his class. We all know what it means. And at that moment, and you can tell that I'm very passionate when it comes to narcolepsy. At that moment, I realized that, what? Pediatric narcolepsy needs a voice, because there were just too many children going through circumstances they should not have to go through. And that was a big one. Needless to tell you, my 15-year-old girl is now 30. She's an adult. She still comes to me. She's getting married, and she has told me that she's never leaving me until I retire. And she's like, and she says, "Oh, and by the way, you cannot retire until there's a cure." And my 8-year-old kid is now a third year in university.
Awesome.
And he's doing engineering. So he was never stupid. He just couldn't learn because he wasn't awake. So you see things like that and you realize, what? Sleep awareness just needs to be done better in general.
Yeah. Thank you so much. So apart from having a significant medical problem, are there other things that happens generally in any home setting that can actually affect and cause daytime sleepiness or childhood sluggishness or adolescent sluggishness that might present similar to sleep disorder that parents or viewers need to be aware of? Because it might not all be medical, but there could be some things that we can, Well,
one of the things I always say is a sleep history is not complete or sleep evaluation is not complete without also looking at the person's sleep characteristics in general. So, you could be tired or sleepy during the daytime simply because you're not sleeping at night. So it is important to understand how much sleep a person is actually getting at night, what time they're going to bed. And I always tell parents and physicians to define the two things differently. Going to bed is different from going to sleep. And it's very funny how a lot of times if I have a child and a parent in a room and I say, well, what time do you go to bed? The parents will blurt out the time because that's when they tell the child to go to bed. And then I'll say, and what time does he go to sleep? And the parents will say the same time. And then I look at the child and the child will be like, no, actually, I'm up for another 2 hours. And the parents are like, what? And I'm like, exactly. I'm like, going to bed and going to sleep are completely different things. So understanding what time a person actually goes to bed and what time they go to sleep are very important in defining, is there prolonged sleep latency? Is there a form of insomnia? And if there is it just psychophysiologic insomnia? Is it chronic insomnia? Or depending on the age, is it just a behavioral insomnia of childhood? They're all very different. But then it's also important to define differently whether it's an insomnia or someone who just has something like a delayed sleep phase syndrome, which is a circadian rhythm disorder, in which case the person is actually capable of sleeping. They just are not on the same clock as everyone else. So if you were to imagine, they're not, if you tell them to go to bed at 9 o'clock, they will stay up till 11. But once they fall asleep at 11, if allowed, they will sleep a full 8 hours as you would expect and wake up at 7 in the morning, But on the other hand, they're incapable of going to sleep at 9. That's different from someone who has insomnia, who goes to bed at 9, is incapable of falling asleep till about 11 or thereabout. But even after they fall asleep at 11, they'll wake up multiple times at night and have difficulty returning to sleep, or eventually wake up around 3 or 4 in the morning and be unable to go back to sleep. So it's important to define differently. Is this just a delayed sleep phase syndrome? Is this a true insomnia? And the reason why it's important to define them differently is because understanding what they are will affect how you treat them. They're not the same condition, and they shouldn't be treated the same way. So I'm always looking at everything in sleep, the behaviors, the timing, the factors around it, because all of these different things will have an impact on whether you are sleeping well or not sleeping well. Movement disorders in sleep, for example, things like restless leg syndrome. It's actually one of the leading causes of insomnia, and is probably the leading cause of insomnia in women of childbearing age. Frequently, it's associated with ferritin deficiency, which is a storage form of iron. Most people are unaware of it. So what? A woman comes to you after having 3 kids and suddenly says to you, you know what? I developed insomnia after my 3rd child. Oh, and by the way, I'm not one of those moms who stands by my child's bed in the middle of the night watching them. I'm not that mom. I'm comfortable with having children. I was happy to put him in his crib right from the moment he got home from the hospital. But for some reason, I can't sleep. And then they put these mothers on sleeping tablets and all, when all they needed was someone to just check their iron, realize that their ferritin levels were low, and replace their iron, and their sleep would have gone back to normal. So women of childbearing age, young girls who are beginning to have periods, girls who are having large periods, more likely to have ferritin deficiency. So when someone comes to me with insomnia, one of the first evaluations that they will always get, I'm going to check their ferritin levels. I'm going to check their vitamin D level, because vitamin D deficiency is associated with poor sleep. And I'm going to check their vitamin B12 levels, because vitamin B12 levels are also associated with poor sleep. If you think about it, our diets, great as they may seem, especially in the Western world, is very heavy with milk and milk-containing products. And if you think about iron absorption is very poor around milk, basic substances, and calcium. So when we get those calcium fortified drinks, and then we're giving the iron fortified cereal at the same time, all the kids are doing is pooping the whole iron out. None of it's getting absorbed. And so parents are shocked. And then if you have a vegan child, God help you, because unless someone is remembering to continuously give them iron, the frequency with which I see severe ferritin deficiency in children who are vegan is alarming. But it shouldn't be that way. I get it if you want to be vegan, but someone should at least advise them of how to replace the nutrients that you're not going to easily get on a vegan diet. And iron is one of them.
It's interesting you mentioned that, because we know that vitamin D deficiency is an etiological factor in a lot of things that could have simply been corrected by just giving people supplements or getting them to eat more food with vitamin D. Thanks for that, Dr. Ajay. I know you've mentioned a few on this. Just to remind our audience that you can please post your questions live on YouTube or Facebook, and I'll get Dr. Ajay to help us deal with that. And so when we talk about things, there are certain myths about sleeping disorder, and I'll mention one that I've had before. If I exercise, I'll sleep better. That is what I hear a lot. And that there are different school of thoughts about that. What do you think about it?
So what I advise people is exercise can help, but exercise should be completed at least 2 hours minimum before bedtime, and it should be moderate at most, not heavy exercise. Moderate at most and completed at least 2 hours before bedtime. It actually can have a positive impact, for example, on people who have restless leg syndrome and periodic limb movement and sleep, but it should be completed at minimum of 2 hours before bedtime. Now, here's a caveat to that. Here's one that actually I tell people all the time. The assumption that if you have a child who's not a bad sleeper, the assumption that you're going to take him to the park, run him into the ground, and then he's going to come home and sleep, that is normally going to lead to him having a night terror. Your night will be horrible because they're more likely to have night terrors if they're overly tired before going to sleep. So do not take your kid to the park and run him into the ground in the hopes that you'll have a good night of sleep. You have a good chance that you're going to end up with a parasomnia instead.
Yeah. Some of us will need to probably go and own up to some of the things we've done to our children when we're young parents, thinking that does work. Okay, thanks a lot for that. For the young adults, and I'm talking about the teenagers, I do know a lot about substance misuse and the impact of alcohol, cigarettes, and illicit substances on sleep, and caffeine misuse and things like that. Are there other specific habitual things that our young teenage people do that can affect the quality of their sleep, and what they need to be aware of? Because teenagers, once they believe something, you need to probably get a textbook of references to.
They're going to go with it. Yeah. Well, you mentioned, one of them, for example, caffeine, like you mentioned. Yeah. Caffeine abuse is an issue in terms of when they drink it. They have no idea how much caffeine is in a lot of those energy type drinks that they like to drink. One of the things I standardly advise people is if you have a history of difficulty sleeping, you should really back off of, you shouldn't take any caffeine containing substances any later than 2 p.m. in the afternoon to give it time to clear out of your systems. I frown heavily on teenagers napping at all during the day because it will affect their homeostatic drive to sleep, which then creates a problem on its own. Alcohol. So people always say, how does alcohol affect you? I'll tell you one thing. Very little alcohol will not affect your sleep. Heavy alcohol drinking you might think you pass out quickly, right, when you're super drunk. But here's the problem with that. Once you're asleep, your sleep apnea, because your airway will collapse more easily and more likely on you. Your sleep apnea will be more severe. Your fragmentation of your sleep will be alarming to a large extent. Your sleep staging will be disrupted. So heavy alcohol, while you may pass out with it, the quality and ultimately the quantity of your sleep will suffer severely from it.
Talking about
when it comes to other things, yes, it comes to other things. There's a lot of use of drugs, marijuana, heroin. That seems to be a growing thing, and especially here in the States, where some substances have become slightly more legalized now. It seems as if in small quantities there is less of an effect on sleep. But as with all things, when you go to higher quantities or higher doses, the impact on sleep is virtually always negative.
And I was just going to add to what you were saying about our teenage group and the current use of electronic gadgets and things like that. You find some of them not sleeping too late in the night. I know that has a lot of impact on them. A lot of our young adolescents are chronically sleep deprived.
Yes.
And what would you say are probably the benefits of having adequate sleep? Because I know as a fact that some of us, even as adults, don't sleep well.
Yeah.
What happens during sleep that is so beneficial to us that we cannot afford not to sleep well?
So a lot of things happen to us while we sleep that are, first of all, your body to a large extent heals in sleep. We produce more growth hormone while we are sleeping, and growth hormone is important for fixing and repairing a lot of those wear and tear, little splits in our muscle groups and stuff like that we have through the night. So our body produces that. Our body has an internal clock to it, and on that clock, different things cycle differently. So, for example, we produce less steroid in the middle of the night, and we produce more steroid during the daytime. That's one of the reasons why people with asthma seem to have more. They tend to develop more asthma symptoms in the middle of the night. Our thyroid production varies depending on whether it's daytime or nighttime. The amount of sleep we have and the quality of the sleep we have, and if we have things like sleep apnea, can affect our cortisol production. If it affects cortisol production, it can also have an impact, for example, on glucose, on whether we become more intolerant to glucose, whether we become more insulin resistant, whether our blood sugars go up in the middle of the night. So a lot of our chemistry is impacted by sleep. People who have sleep apnea, for example, are more likely to develop insulin resistance, and along with insulin resistance, they're ultimately more likely to develop diabetes. People who with sleep apnea and people with insufficient sleep are more likely to have elevated cortisol levels and are more likely to develop high blood pressure, invariably as a result of it. People with untreated sleep apnea will develop asthma. I mean, there's just so much stuff that is impacted by whether we're asleep or whether we're awake and all of that. But when we sleep, and we sleep well, we dream. When we dream, it helps with our memory. It helps with coding both our short-term, long-term memory. So good sleep actually helps us with coding our memory so that we actually can retain information better. Good sleep helps with our blood pressure. Good sleep helps with our healing. So there's a lot of important stuff there. Good sleep helps us ultimately with our executive functioning, with our neurocognitive and neurobehavioral health. I mean, you don't have to be a child to see what happens if a person doesn't sleep well. Adults that don't sleep well misbehave. Talking about kids who don't sleep well. So, so it's just something that you have to do.
Yeah. That is something that I think was important for us to kind of air out to our young adults. And I've got somebody who's just asked us online that is taking sleep medicine advisable for teens. What would it be for teenagers?
So I don't ever want to give a blanket answer yes or no without actually knowing why. However, here's what I will say. Your child should not be on a sleep medication without you, first of all, having someone define clearly what your sleep disorder is. And in defining what that sleep disorder is, understanding whether it is a sleep disorder that could be managed with medicinal options. And I'll give you a simple answer in this way. Virtually every form of insomnia, which insomnia is inability to sleep, virtually every form of insomnia in children as well as adults, in the exception of acute insomnia. And when we say acute insomnia, what I mean is an insomnia where there has been a significant event that has led to it. So a child has lost a sibling, a child has lost a father or a mother, and now he can't sleep. Yes, give that kid sleep aids. Give the adult sleep aids. But don't just give them sleep aids. Give them sleep aids and immediately address the reason for not being able to sleep. If you need to send them for grief counseling, if you need to do something, immediately do it. So, and that's what we call acute insomnia, where there's this new onset insomnia, there's a clear reason why it's happening. Yeah. And you need to get the person to sleep, because if you don't get them sleep in that situation, they can develop a chronic insomnia over time and a lot of the maldevelopment that goes along with it. So that is the only situation in which a child or an adult, in the case of insomnia, should ever be put on medication as a first step. Otherwise, medication first is always the wrong answer. What you end up doing is you create a dependency on a drug that a child probably virtually never needed to be on, because you could have fixed it with cognitive behavioral therapy.
Yeah. And most of these drugs also have got their own side effects and potential long-term effects, memory, and also of other things. So it's important that if we have, like you're saying, if we have parents who have concerns, it's important to actually get a diagnosis. And if you're using sleep tablets, a lot of people, I know what we're talking about here is a lot of people will do self-medicate. For various reasons. You have trained doctors in their houses and from friends who have talked to them, and they do all sorts of things. But some of these things could have a long-term.
It can happen, and that's the problem. Sometimes some parents will say, well, I just gave him a little bit of diphenhydramine, or I gave him a chlorpheniramine, a Piriton tablet or something like that, just to get him to sleep. But my thing I always say to people is, the ability to sleep is a completely natural, normal phenomenon, as normal as breathing is to us. So the first thing you need to always ask yourself is, if I can't sleep, why? Yeah. We really need to do that, because without knowing the why, what ends up happening is you will create a habit that then becomes an issue, because it is so much harder to do cognitive behavioral therapy once someone has found out that they can just pop a pill and go to sleep, because then that becomes a habit and no one wants to do the hard work anymore once they've done that.
Thank you so much. And I know we've kind of moved a little bit towards some supportive treatment for people with insomnia. How is sleep disorder diagnosed?
The best and easiest way to diagnose a sleep disorder, truthfully, is a history. The sleep is one of those conditions where I can probably diagnose virtually 90% of the sleep disorders out there, or what's wrong with a person, simply by having a chat with them. The only sleep disorder that requires a formal evaluation in terms of a sleep disorder is snoring. Because if you've got a person who's snoring, ideally you should do a sleep study to define whether it is just primary snoring or whether it is true sleep apnea, and to see how to treat it. But outside of that, everything else with sleep can be defined and treated by a history. And in fact, when I do a lot of my appointments, whether they're in person, or I also do a lot of telemedicine appointments for people who I'm calling from wherever they are on the planet with me, all of these things are done through, I can do it through history. I can send them logs, have them fill out sleep logs for a couple of weeks. I can review their sleep patterns through their sleep diaries and tell them, okay, here's what it's going on. They supply me with information. But it's really, if you've got a physician who's got an ear for listening, sleep becomes incredibly easy, because you can quickly tell what needs to be sorted.
Thank you so much. So we're talking about history. Are there other kind of more intense investigation that needs to be done? You mentioned something, blood tests. Yeah, fine. Are there other things that
So, so if I was to look at it and just take it in a simple form, you would go history, right? You do your history, you do your physical. I like to send people what I call sleep diaries or sleep logs. And the reason for that is just like if I asked you, what did you eat day before yesterday for lunch? Oh, and how much portions were in it? You're not going to remember that anymore, right, today, because it's simply not that. But it's the same thing with sleep. If I want to get a good sleep history from someone, what I do is I send them a log and I tell them to go ahead over the next 2 weeks, note what time you went to bed, note what time you went to sleep, note how long you slept, note how many times you think you woke up, note what time you got up in the morning. After you got up, how did you feel? Were you awake? Were you alert? Were you focused? How did you feel during the day? Did you need to use any medication? And then do that for me for 2 weeks. So when you send that in to me, I can tell right from that piece of paper, right from that sleep log, I can look and get and already begin to form an idea of what they're doing. Are they going to bed too early? Are they going to bed too late? Are they sitting in bed too long? You know, are they staying in bed too often? Are they having prolonged wake episodes? Are they having them more in the second half of the night? Is it more in the first half of the night? This is all super important information when you're trying to figure out what is wrong with someone. But not all of it, it's the only intensiveness is just in them filling out a piece of paper and all of that. That's really what a lot of sleep is about. The only time, like I said, that we would say, okay, now you have to come in for an actual sleep in lab study evaluation, which we call a sleep study. And a sleep study is where you come into the lab and I will hook you up to computers and I'll look at your brain activity through the night so I can see whether whether you're sleeping, whether you're going into all the stages of sleep, whether you've got sufficient time in each stage of sleep, what's happening with your oxygen level, how's your heart readings, what are your limb movements. That's what we call a sleep study. Sometimes we'll do that. But that's only required if you have someone who snores and you're worried about sleep disordered breathing. So like my sickle cell kids, the Down syndrome kids, any child with large tonsil and adenoids, those are the kind of patients you would look at with that, or someone who has a muscular dystrophy. But if it's just a person whose big complaint is, I can't sleep, or I'm very tired, the first and most important part of evaluating them always is going to be a history and physical and sleep logs. We virtually never need any imaging. So imaging like MRIs, CT scans, we virtually never do any of those unless a person has a sleep study that shows significant central apnea, in which case I would then do an MRI of their brain because I'm looking for a Chiari malformation or a posterior fossa tumor. But those are the only situations where I might do something like that in those patients.
All right. Thank you so much. I think one of the other things I wanted to add on to what you were talking about, common causes of insomnia, is my concern for also the young adults, especially the students, and some of the medical students that I have. I'll probably need to sell them all sleep diaries and and the ones I mentor to actually find out how much sleep they are getting, because they seem not to understand the impact this can have on their studies and their performance and their ability to hold information and retain information and to be able to do well. And also, the opportunity for me here is also to mention to young adults, please don't mix alcohol and energy drinks. And as most of them do that to be able to drink more when they go on a night out, it is extremely dangerous. And that's all I'm gonna say for you tonight. And there might be other opportunities for us to expatiate on that when I do some more talk on substance misuse in the near future. So, Dr. Ojai, what is the role of CBT in managing sleep disorder?
Cognitive behavioral therapy.
Yeah.
Yes. So cognitive behavioral therapy, basically, for people who may not understand it in the purposes of sleep, it talks about a set of non-medicinal techniques, pretty much behavioral modification techniques that are used to improve or change or modify behavior. And in this specific case, looking at how it impacts sleep. So cognitive behavioral therapy is actually very effective and is considered the first line, for example, in the management of insomnia, which is a big part of sleep disorders. The key thing for people to understand when you're looking at that is, in order to use cognitive behavioral therapy effectively for insomnia, you must first determine what you mean by insomnia. Because insomnia is a very big basket. Insomnia just means difficulty sleeping. But you need more than that. You need to know, is it acute insomnia or is it chronic insomnia? If it's acute insomnia, like I said earlier, you want to use medication right away and combine it with fixing the reason for why the insomnia developed, whether that's through psychotherapy or whatever, or some sort of psychological evaluation. But if you have chronic insomnia, then I'll give you an example of how we split it. If you have psychophysiologic insomnia, which is one of those situations where you have those people who lie in bed and they'll tell you that they go to bed, they feel tired, they go to bed, but then once they hit the bed, their mind starts racing, they've got thoughts flying through their heads, they can't seem to worry, they can't seem to let it go. Then they start thinking about tomorrow, and they start thinking about school, and they start thinking about everything that's going to happen, and then they start worrying about, oh my gosh, I'm not going to be able to sleep, and because I can't sleep, I'm going to fail in class, and I'm going to do all these things. So not only are they not sleeping, their minds are worrying, and then they develop these very, very unhealthy thoughts and impressions about sleep. Well, for those group of people, for example, they need cognitive therapy, where you actually have to reteach them about what sleep is, the importance of sleep, and to actually change and disabuse their minds regarding some of the incorrect thoughts or expectations that they have about sleep or what will happen if they don't sleep. For some of those people, I would end up having to use something like paradoxical intention as a technique for trying to actually get them to sleep by actually reversing things on them. Some of the times we will use relaxation techniques to help with helping that kind of person to bring down their arousal index and stuff like that, to try and help with them. In some cases, you want to use techniques such as a faded bedtime or sleep restriction pattern, where you limit the amount of time a person spends in bed to the amount of time they spend sleeping, and then we move the clock and adjust things. So there are lots of different techniques that come within CBT. So not everything applies to everyone. You kind of have to understand what is wrong or what is causing the insomnia in order for you to pick the right one. So I'll give you an example. If you're dealing with a child, for example, with a behavioral insomnia of childhood, you would not manage limit setting sleep disorder the same way you would manage sleep onset association, because they're completely different. With a bedtime sleep disorder, it would be a lot more effective to use bedtime passes with a reward system to reinforce good behavior. While in someone with sleep onset association, you would really prefer to use what we call a graduated or complete extinction technique, which for the uninitiated means let them cry it out. But if you try and use graduated extinction or complete extinction with someone with limit setting sleep disorder, it won't work. And if you try and use a bedtime pass with a reward system for someone with sleep onset association, it won't work. So you need to know what technique works with what thing.
Right.
Exactly. Otherwise, you don't get the results you're looking for.
But there is a role for CBT, which is
absolutely should always be the first thing you try.
And at what stage would you start to, for you as a physician, at what stage would you say I need to start intervening with medication?
So let me put it this way. I'm going to define what kind of insomnia you have. I'm going to look for any medical things that can impact that insomnia, because it is virtually impossible to treat an insomnia in the presence of a medical condition that's causing sleep.
Yeah.
So I'm going to do a lot of digging first to figure out exactly what's wrong. I will be honest with you, Nee. Because I know how to do those so well, in terms of digging, looking, finding, the only patients that I typically end up having to use some sort of medication to help with their sleep is typically children with autism. And in that specific group of patients, CBT, cognitive behavioral therapy alone, simply won't work because there is something inherently different that has impacted their ability to sleep, and they need help.
Yeah.
But even in that group of patients, you can get away with incredibly intelligent dosing of melatonin or melatonin analogs or agonists such as Ramelthion to try and help with regulating sleep. You don't need to necessarily go with a club to knock them out. You can typically get away with that. And so I use different techniques. But when I also look at sleep, I also look, for example, at an insomnia patient, and you have to look at it and ask yourself, is this person's problem an inability to develop a sleep drive, or do they have a sleep drive, but the big problem they have is they have a heightened arousal index? So which one am I actually trying to fix? Am I trying to increase your sleep drive, or am I trying to reduce your arousal index? And when I understand which one I'm trying to treat or do, that's what I go for. Because if your sleep drive is already fine, but your problem is your arousal drive is too high, then that's what I need to bring down. I don't need to drive your sleep up anymore. I just need to bring your arousals down, your arousal index down. So, I mean, sleep is really cool. I'll tell you that much, because there's so much that's going on with it. And one of the fun things I always say about sleep is every single patient is a custom case. And by that, I mean, what you apply for one person, you cannot apply equally to the next patient because they're completely different.
Yeah, absolutely. Thank you so much. And so we when we look at sleep management, totally a good history, and actually getting an idea of what the sleep problem is. Sleep diary is important, which is why in my own job also I always do alcohol diaries, because I need to know how much you're drinking every day for me to even know where to start from. Otherwise, you're just working from a blank page. You don't know exactly. What you're doing. And I think for parents, and I'm more specific about parents, and I'm sure that this is the reason why I feel this program is extremely important tonight, in that children are suffering because these disorders are being missed, and they're being disciplined, they're being deprived a lot of things because they think they're just misbehaving. I'm not saying you young people don't misbehave. Well, I'm sure I remember you very well. You did your own. But yeah, it's part of growing up. But it's when something is having a significant impact on a child and it's being missed, I think that is a big concern. So I think for parents, the reason why we're bringing awareness to parents and even to teachers sometimes, being a good teacher can just be you are able to identify students who have issues like this in your class. You're the best. And it's not necessarily the fact that these students are not able to assimilate, or because you're a bad teacher. It's just that they just can't. And because people are missing a lot of them. For example, ADHD gets missed a lot in young children, and they just think that they're just destructive. So we need to begin to look at these things more intently. And I think one of the things that we need to do is probably just have more relationship with our children also as they're growing up, so you can know when there's something not right. And if a child is saying that there's something wrong somewhere, it's important for us as parents and as carers to take that on board. I know that a lot of people want to know whether there are other complicated ways of managing sleep disorders.
Complicated, or you mean less complicated?
Go for surgery in managing sleep disorder.
So yes, in a child that has sleep apnea, removing the tonsils and adenoids is actually considered a treatment of choice for the management of obstructive sleep apnea. And it does have a significantly positive impact. It reduces sleep fragmentation. It reduces restlessness. It improves neurocognitive functioning. There has been a noted grade point improvement in kids' academic performance if they have sleep apnea. So you can't just take out the tonsils just because they're large. You have to define, first of all, that they actually have sleep apnea, and if you can, then you should do it. That is typically the only situation where surgery would be considered optimal in the management of a patient with sleep disorder. The only other time we might use it is if we have a kid with what we call central apnea, where their brain forgets to tell them to breathe, and we do an evaluation and realize that they actually have a Chiari malformation with a tightening at the base of their brain affecting the flow of fluids, in which case we might recommend a posterior fossa decompression, where they do a little membrane dura mater excision to and chip the bone to open up the space. But other than that, there isn't really in children any other room for surgery.
Any behavioral complications that can be associated with sleep disorder?
Oh, seriously, very serious ones. So I'll tell you that learning disability or learning dysfunction, loss of executive functioning, reduction in IQ points associated with low oxygen saturation, increased distractibility, poor focusing, increased development of depression, worsening of general anxiety, all associated with sleep. So lots of unhealthy things.
Well, lots. And I also know that for those of us who have grown up to know uncles and aunties and everybody who don't sleep, they worry about contracts, they worry about this. They don't sleep in, the blood pressure goes up, the anxiety rises, and people are actually prone to actually having either a cerebral event or something, or even a cardiac event. All right. I know that people will not forgive me if I don't ask you this, Dr. Ojai. What dietary modifications are useful in managing sleep disorders?
Dietary modifications. So it depends. You know, we're all very different in general. I'll tell you that people seem to do a bit better with sleep on a more heavily proteinaceous diet at night. So that's one thing. With kids who are very sensitive to sugars, you may want to reduce carbs at night, because then they sort of bounce off the wall with the carbohydrates. So you kind of want to cut back on that. Fatty foods don't really affect sleep much. If you have a person who has things like gastroesophageal reflux, you definitely want to try and make sure that dinner is completed at least, if possible, 3 to 4 hours before bedtime, because you don't want reflux, because that will also disrupt sleep. Because remember, sleep disruption isn't just about going to sleep. It's more about going to sleep as well as staying asleep. Both things are equally important there. So anything that's going to affect your ability to stay asleep will also be an issue. So a lot of kids seem to be very sensitive to sweets and stuff like that. So if they are, and if you've got a child who gets very hyper with sweets, I would typically recommend that maybe you keep them off from at least about 4 in the afternoon, or if they're going to bed, at least make sure they have at least 4 hours between that and whenever they're supposed to go to bed. I think that's probably the most important thing that I would say there from a dietary perspective. Stay away from caffeine as much as possible. But it's not just caffeine in terms of your coffee. When I'm talking caffeine, I'm talking about the fact that there's caffeine in Coke, there's caffeine in Pepsi, there's caffeine in a lot of those energy drinks that you're drinking. If you're someone who has difficulty sleeping, then ideally you shouldn't be taking any of those things after about 2 p.m. in the afternoon. So I'm not saying don't drink it at all, but you have to know when to stop it so that it doesn't have an impact on you on the backside of things. So that's super, super important for you to know when it comes to that. Other than that, honestly speaking, if you don't have a sleep disorder, you don't really seem to have any problems at all with virtually any foods. So I would say that generally you're good. If you don't actually have a sleep disorder, you don't have to worry about your diet at all. But if you do have a sleep disorder, then yes, you do have to worry about your diet.
Great. Thank you so much. And also, is there any role for herbal supplements?
Beg your pardon?
Herbals.
So, so it depends on what's going on. So, for example, there are people, melatonin is typically not regulated in a lot of societies. It's not a prescription in a lot of places. I'm not sure if it is in England, but it's considered more of a over-the-counter, more natural analog that can be used to help with sleep. a lot of times the problem is figuring out how to dose it appropriately. Should you take 0.5 milligrams? Should you take 3 milligrams? Should you take it around 5 or 6 o'clock, which is about 2 to 3 hours before when you actually might go to sleep and before your dim light melatonin onset, or do you take it right at the time of going to sleep? The truth is it should be taken earlier, not later, but most people don't realize that. There are things like valerian root, which can be used as a tea. There are some agents that we try to stay away from, like kava kava, which is a form of it can help with sleep, but has also been noted in some situations to be associated with significant liver dysfunction. So you have to be careful about that. L-tryptophan, which is what people normally say makes them sleepy after they've had turkey. But there are things like that. But again, if you need to be on something for sleep, I have no problem with someone trying out a herbal aid to see if it will help. But what I always say is, before you do anything, before you put any form of medication into your body for sleep, the first thing you have to first of all define is, why can I not sleep? Don't treat without knowing why you have to treat. And I think that's probably the biggest thing that I will say is, it's not okay to treat without knowing what you're treating. And too often that's what happens, is we're popping things into our body without understanding why we're doing it and if we ever would have needed to do it. So whether it's valerian root, passion flower, lemon herb, chamomile, you've heard all of these things. One thing I have to tell people before we finish up this show and all is showers and baths, because people always ask about that. Do realize the only people who sleep better after a shower or a bath are people who have no trouble sleeping in the first case. If you have insomnia, a shower or a bath wakes you up. It does not help you go to sleep. If, on the other hand, you have no trouble sleeping, you will sleep like a baby. But if you have trouble sleeping, you're not sleeping. So one of the standard instructions I give to people that have insomnia is you must complete your shower at least a couple of hours before bed. If you've probably noticed, there's a theme here. Virtually everything has to be finished at least 2 hours before bed. So you're going to have a log jam if you're exercising, eating, and taking a shower, because you got to finish up 2 hours before bedtime on all of those things.
All the alarms in the house set for 2 hours before sleep. All right. I've got a question here for you, Dr. Ojai. It says, will having large amount of chamomile before bed or through the night affect my toddler's sleep? He's 2.5 years old.
Oh, well, now chamomile is a natural herbal sleep aid, so it should help your child sleep.
Cow's milk.
Oh, cow's milk. Okay. Honestly, shouldn't make much of a difference, but I would probably make sure you're not giving him too much to drink at night, because you don't want him, especially if he's a snorer, you don't want him refluxing, because if you give him large volumes of liquid and he's a snorer, snoring will induce reflux. Reflux will trigger arousals from sleep. So he will arouse multiple times during the night, not because he's hungry, but because that very food you gave to satiate him is coming back to wake him up.
Yeah. And is there any role for actually finding out and saying, why does he have to have cow's milk throughout the night?
Well, he shouldn't be, because the first thing I always tell people is every child should be able to sleep through the night without food the moment they've doubled their birth weight, and typically by no later than 6 months, at which point developmentally we expect them to have already doubled their birth weight. So kids should be sleeping through the night by about 6 months, and certainly shouldn't require an extra meal at night.
All right. Thank you so much. And before we go to the last aspect of this that I would like to bring to our audience is, how can sleep disorder be prevented if it can?
How can they be prevented? One, good habits.
Okay.
It starts early. You mentioned something earlier on about electronics.
Mm.
Electronics can be a big, can have a big impact on sleep. Now, remember, the first thing is in defining a sleep disorder, there has to be an impact on daytime functioning for you to consider it a sleep disorder. So, for example, if I'm only sleeping 5 hours a night, but I'm waking up in the morning refreshed, fine, bright-eyed, able to function fully during the day, do all my work, finish up, go to bed when I know I can fall asleep, and then wake up the next morning 5 hours later and good to go. By definition, that would not be considered a sleep disorder. That person would be considered a short sleeper. Now, having said that, I will tell you that that invariably is not sustainable because you need over 6 hours of sleep in order to sustainably manage your health. Otherwise, you will begin to develop issues related to that. So you need to kind of know a bit more about that in general. But I will say that in general, when I think about what people should be doing and what people can do related to their sleep and when does it become a problem, the first thing is understanding what's going to impact you during the daytime. Electronics are an issue. A lot of people are playing games now online. Now, it would be okay if the person you were playing a game with was in London while you were in London. And so you were both on the same schedule and you both had to go to bed at the same time. The problem is sometimes you're playing games with someone who's in London, who's playing games with someone who's in Los Angeles or in Brisbane in Australia. And then you're not on the same time schedule. And, we both did it growing up. And, I remember being on a Commodore 264 playing Wizard of War. And literally, I think I played it throughout the whole night and into the morning. And I realized how tired I was the next day. And we only had access to those games a few times. So imagine someone who has access to them all the time. So electronics need to be controlled. People have to be disciplined about putting down their electronics. That will have an impact on their sleep. People have to understand that our behaviors will impact sleep. A noisy environment will affect a person's ability to sleep. A room that is too hot will affect your ability to go to sleep and also affect your ability to stay asleep. A sleep environment that has multiple people on different sleep times can impact sleep negatively for different people in that environment. And even among adults, a snoring husband or snoring wife can completely destroy the sleep of their partner just because of that. So, yeah.
And one of the things that you actually said earlier on in the program that I think it's quite important is that there is a lot of people, especially of African descent that I know, and even in other population who have sleep apnea and they are not aware of it. I know in those days when we're in medical school, they will say to you that if your neck is more than 18 and you have a circumference of so and so centimeters, you need to actually go find out whether you've got it. And I think that still suffices. Really.
It is true. It's actually, if you've got a neck circumference of over 17.5 inches, and if your waist as a man is over 35 inches, you've got a very strong likelihood that you've got sleep apnea. And so that feeling that being rotund is associated with healthiness is actually wrong.
Yeah. So people who are trying to have biggest tummy is not advisable.
Not advisable.
All right. Well, because we're running out of time, in 5 minutes, Dr. Ojai, can you please kind of give us a kind of quick on sleep hygiene that are quite important, that can be useful in sleep disorder before we round up?
So sleep hygiene, by its very definition, just talks about all those behaviors or habits that you do around bedtime that are typically important in terms of helping you go to sleep. So if we take sleep from the top and work it downwards, I always tell people, I have people tell me all the time, I'm trying to go to sleep. And I'm like, okay, back up. That's where things have first of all gone wrong. You shouldn't have to try to go to sleep. The actual act of sleeping is actually quite normal effortless for most people. If you think about it, you're looking at a wristwatch, you suddenly realize it's 1 a.m, and for some reason you have to go, maybe you're hanging out with your mates on, for example, so it's 11 p.m, but then you realize, oh gosh, tomorrow I have to get up at 5 a.m. because I have a meeting. You hadn't yawned once, you didn't even appear tired at all, but you suddenly say to your mates, guys, I have to go to bed because tomorrow morning I have to get up early for a meeting. You go to bed, you go to the bathroom, you go to bed, you put on your pajamas, you go to the bathroom, you urinate, and then you hop into bed. And literally within 5 minutes, you're asleep. You didn't have to squeeze your eyes tighter than usual to help you sleep. You can't do that. It just became natural because there are certain things that we call cues that are important in sleep. So here's one thing I say to people. If you have trouble sleeping, for example, you should not put on your pajamas until it is time to go to bed. Why? Because the act of putting on your pajamas and actually wearing on your pajamas should be a cue to your brain to tell you it's time to start winding down. Your putting on your pajamas should send a signal that says it's time to go to bed. And so I frown on people taking a shower at 4 p.m. or 5 p.m. when they come home from school and then putting on their pajamas and toddling through the house for the next 4 hours. That's really bad. If you don't have insomnia, you can do whatever you want. But if you have insomnia, you can't. You can't get into your pajamas right then. You have to get back into your street clothes, even if you take a shower, because wearing your pajamas is part of the process of actually going to sleep. Another thing is your bedroom. If you have no trouble sleeping, I don't care if you live in your bedroom. However, if you have trouble sleeping, you should not be in your bedroom unless you are going to bed. So going into your bedroom should be a cue that sends off a signal to your brain that says, I'm going to bed now. So for someone with insomnia, they should exist outside of their bedroom because you want everything about their bedroom to be associated only with the act of sleeping. Lights. Preferably, you want your room pitch dark or with as little light as possible because darkness is important for sleep. The brain's ability to produce melatonin is improved in the presence of darkness. You do not produce as much in bright light situations. I'm quite sure cavemen probably didn't have as much trouble sleeping unless they were worried about being eaten. But other than that, I'm sure it wasn't an issue with melatonin because they lived in the dark. So that's something important to know. Another thing that's important, a lot of people like listening to music at bedtime. Now, it's a two-edged thing. I'm actually not against music. I don't think it should be loud. Make sure that it's low in intensity. But most importantly, have a playlist. A familiar playlist is white noise. And by that, I mean, if every song that's following the next song is a song that you already knew or you knew it was coming, you actually don't think about it. It just plays in the background, it disappears into the background, and it doesn't impact your sleep. A radio, I frown against a radio because a radio is too spontaneous. What's even worse is a radio with a DJ or a commentator, because what you don't want to do is be drifting off to sleep. And then someone says something that catches your attention. And now you wake up because you're listening, or you're drifting off to sleep and a song comes on that suddenly excites you because it's not something you've heard recently. So it comes on and now it impacts you. So those are some of the things that we look at when we're looking at sleep hygiene. And then I'll probably say in closing, from a sleep hygiene perspective, it is incredibly unhealthy to be in your bed for more than 30 minutes if you're unable to go to sleep. So you really need to, you should not, sitting in bed is not the way to do it. Reading in bed is not the way to do it. Watching television in bed is not the way to do it, especially if you have insomnia. If you don't have insomnia, I don't care if you've got an entire movie theater in your room. You can do whatever you want. But if you have trouble sleeping, we have to control it.
I know that parents have this habit of checking on children regularly. And I'm even without asking you, I can see the shaking of the head. That frequent checking will probably.
Well, one of the problems with checking, for example, if it's a young infant, is it creates confusion. You know, when we talk about the extinction technique, which is a cried out technique for people who have insomnia, graduated extinction is actually less effective than complete extinction. Graduated extinction is where you keep going back. Maybe you go back after 5 minutes, then you go check on them after 10 minutes, then you go and check on them after 15 minutes. The problem is the child doesn't know if you're coming back because they cried louder, yelled more, threw up enough times, or if they just didn't cry enough and that's why you haven't come. If you do complete extinction, which is where you just decide, I'm not coming, go to bed, boom, closing the door, I'm leaving. Don't lock it, but just close it. Typically, with complete extinction, virtually every case of sleep onset association will resolve itself in less than 2 weeks. And then thereafter, at about the third week, you will have a reemergence of symptoms as the kid tries to kick back. And if you ignore them, it lasts about 2 days and then it disappears. If you use graduated extinction, it takes a lot longer because you're just trying to build and fix something, but you're creating confusion while you're trying to fix it. So stay away from that if you can.
Wow. Somebody's just asked whether hypnosis and meditation can be an alternative treatment for sleep disorder.
They can be, but it's very hard to get good professionals that know how to do those techniques. Very, very hard, but definitely not the first step in trying to fix it. But yes, they absolutely are techniques, but very hard to find professionals who know what they're doing.
All right. Brilliant. And we'll need to draw this to a close because we've gone ahead of our time a bit. And I'm sure all our audiences will all over the world will help me in saying thank you for your time and for always obliging us on this show. So for me, the key points, I think, are these, that it's important that we have a thorough sleep history, screening for primary sleep disorder. We should strive for a diagnostic-driven treatment, not just doing things haphazardly, and consider patient and family characteristics also when we're talking about the impact of sleep on the family and things like that, and optimizing the control of daytime symptoms for underlying or any other comorbid psychiatric or psychological problem is important. And you did mention that behavioral treatment should be used first whenever possible, and medication should only be considered as the last result and in conjunction with behavioral intervention. And if we need to consider medication, especially for acute sleep, acute insomnia, it should be a temporary measure and re-evaluated on a regular basis to see whether there's still need for it while you address the primary problem of the sleep. And I think one of the things that we don't do, especially where I come from, is people don't think that there is need for counseling after a death in the family, or whether a child needs bereavement counseling or need to walk through that grief reaction and support it through that process. They just think they will just get along with it. It is extremely dangerous, and because it impacts on people's psychological health as things go on. And I've seen this happen numerous times as a psychiatrist. Dr. Ajayi, thank you very, very much.
Thank you.
It's always nice to see you, and I always like to hear you speak on interesting topics like this.
Absolutely.
So thank you so much. And this is Health Matters with Dr. Ajayi, and our guest today has been Dr. Akin Ajayi, a renowned pulmonologist from Florida. Thank you so much once again.
Thank you.
And I'm sure you will oblige us again if we need to get you on this program.
Absolutely.
Thank you so much. And from us, this is Health Matters with Dr. Ajayi, and we'll see you again next time. Thank you.
Lifecom Broadcasting Network TV, aka LCBN TV, is committed to bringing the transformation message of Jesus Christ into homes across the world, providing hope in the most desperate situations. We are passionate about souls, reaching the lost, the hurt, and the lonely, and by a click of a button, God can change a person's life forever. Watch LCBN TV channel 24/7 on UK Freeview channel 271, Roku TV, Amazon Fire TV, Android TV, Apple TV, See Love World, Google TV, LCBNTV.com, LifecomTV.com. Download LCBN TV app